Welcome back, everyone, for Health and Happiness. I'm Dr. Farzanna Haffizulla. I am thrilled. With me today, I have Dr. Nancy Klimas. She is our director of the Institute for Neuroimmune Medicine and physician scientist, professor of immunology, world-renowned in her field. So, Dr. Klimas, I'm excited to have you here. Welcome.
Thank you. It's always fun to be here.
Excellent. Well, you always have amazing information to share. The latest and greatest science, the evolving science, on viral illness and long COVID. I know that you've come from some academic conferences recently. So to this time point, if you want to share any news with our community right off the bat, or do you just want to give a little overview of what long COVID and post-viral illness really is?
Yeah, let's start there because maybe some people aren't that clued in. Because it's really very interesting. For the longest time, many, many years, I've been studying an illness called myalgic encephalomyelitis, which is chronic fatigue syndrome. It's the old term. Anyway, it's an illness that's also post-viral, that people have a viral illness and essentially it disrupts their health and they never get back to their state they were before they were ill. Sometimes they're profoundly ill. So I've been doing that for a long time. And then COVID came along and I went, oh my gosh, this is going to be bad because my world is post-viral illness. Sure enough, there's an illness that's termed now long COVID, and it's precipitated by having COVID infection. And interestingly enough, it doesn't matter how severe an infection, even asymptomatic COVID infection can trigger a total reset, if you would, of the body into a state of chronic inflammation and a lot of different types of symptoms that can be very debilitating. So my world now, and still has the CFS piece to it, but also has embraced this long COVID thing because we were really in the best position to deal with it. It's interesting when it first came out, how many people have been affected. More than somewhere between 8 and 15% of people who have ever had COVID infection have long-term persistent symptoms. Well, think about that. We've all had COVID infection, with an extremely rare exception. That means 10 to 15% or so of the whole population right now has symptoms that they did not have before, and some of them enough to take them out of the workforce and even be totally bedbound. So it's a very serious illness. One of the things that came from this conference I was just at was even those of us that feel well have a signature of having had COVID that's inflammatory. So even if you don't feel that bad, just having had COVID turned on a chronic inflammation signal in your body, all of us, that might be a little below the threshold of feeling it, but is not very far from the edge of feeling it. So now there's a worry, even for people who don't have the diagnosis, long COVID. What does it mean for your heart health? What does it mean for your brain health? What does it mean to live for the next years of your life in this different state that puts you at higher risk for other things to happen?
That is such an important point, talking about sort of raising that baseline of inflammation. And now we're seeing diseases precipitated at even younger ages, and different comorbidities play out differently in the long term. We're seeing that in internal medicine practices.
Absolutely.
And so how is that now going to impact screening? And how is that impacting our care of patients? Should we be looking earlier on for some of these markers of disease?
Does it change things? I mean, exactly that. Actually, just think about early on. In CFS, which we know very well, menopause occurs 4 to 8 years earlier. So you have these people that are putting off their childbearing because they're sick, thinking, I'm going to get better. But meanwhile, at the other end, their number of years they have available for childbearing is getting skinny. And I mean, these things really matter. And for women's health, earlier menopause isn't good for you. The fewer years you're living with estrogen, the more cardiovascular risk you have.
And talking about women and how the disease states manifest, looking at long COVID and post-viral illness, how are women different to men physiologically when it comes to the manifestations?
And this is a big women's health issue. Women in general have more inflammatory illness by a lot. If you were in rheumatology, you'd see that maybe eight times as many people have autoimmune diseases are women as compared to men. And there's just a couple of men's autoimmune diseases, Reiter syndrome and ankylosing spondylitis. But, rheumatoid arthritis, lupus, all the other big autoimmune diseases, those are predominantly women. Well, the same goes for long COVID and ME/CFS. Women are at higher risk, and it's something like 80% of the cases are female, 20% men, in that range. So women are at high risk. The reason why is testosterone's anti-inflammatory. So, testosterone is your friend if you're a guy. And for those in internal medicine, primary care, it makes us want to watch testosterone levels in men, right? Because
Absolutely.
testosterone failure can also happen post-COVID and make them more inflammatory and put them at higher risk for these types of things.
Those excellent points. So looking now at how we evaluate patients, right? What information should patients be coming in to be evaluated for either any post-viral illness that might be impacting their disease states? What kind of information is important for our audience listening? They need
So
to
usually when someone gets to an expert like me, they've already been through their primary care doctor who's done the right thing, which is my symptoms are fatigue and pain and non-restorative sleep. And the big one, dysautonomia, which is when your blood pressure and your pulse and all the things you don't have to think about are dysregulated. We should go back to that because that's a really important part of that. But all these things sort of come together in a constellation of symptoms. So if someone walks into your primary care, what are they going to check? You're going to check your thyroid. They're going to make sure you don't have sleep apnea. They're going to do the most common types of things that could cause fatigue and chronic pain and inflammation. But failing all that, having ruled all that out, and then they're going to go, oh my gosh, it's not in the silos that we're used to seeing. Maybe this is one of those long COVID cases. And then someone like me will look a little deeper at different ways of looking at inflammation. Like say a primary care doctor might look at C-reactive protein as a common thing, or a SED rate. So it's a way your immune system makes inflammation by making immune complexes. But these viral diseases aren't very immune complexy. Those look perfectly normal. I look at it with a cytokine panel and I see inflammatory cytokines, and I go, well, that's inflammation of a different type. But it's equally very important.
So the cytokine panel only will be available when they get to your level, essentially, right? At the expert
usually.
phase.
I think some doctors know how to use it because it is on routine lab panels. You can order it, but what do you do with the information?
Exactly.
Actually, I don't know how sophisticated your audience is, but in diabetes we have something called the A1C, which tells you what your sugar's been lately, not what it is in this minute, because sugars go up and down minute by minute. Well, cytokines do too. Cytokines are very reactive, so you have to catch it high. But they have another A1C-like thing, which is the receptor. So we can look for what's called the soluble receptor for inflammatory cytokines of different types and see what it's been like lately. And that's actually a better marker as a clinician than measuring TNF or IOM. Yeah.
That is very actionable information. Is that something you think is covered by many insurances? Is it an expensive test to order?
It's not expensive if it's on the test menu. I mean, we have a lab here at Nova. We offer it, and it's not expensive. But if Questra LabCorp is your lab, you have to dig around and find these. They're not the ones you're
exactly.
It's not on your CBC, your easy checklist menu that you have at the end of your note.
That's right. But it's good information for us you can ask your physicians about this, everyone, right? That's important information. That's an excellent point. So other information that people should be aware of, and if you wanted to even talk too about the common constellation of symptoms.
Yeah, I'd like to talk about the dysautonomia because when I like to take the view from outer space, because as physicians, we tend to silo out things. There's inflammation, there's cardiovascular things going on, there's endocrine things going on, and so on and so on. I like to say, okay, if I could go way up above that and look down on that, how does it mosaic into the right picture so that you can see the whole thing? So here's an incredibly important feature of the long COVID and ME/CFS. Surprisingly, we didn't recognize this very well in ME/CFS. Perfusion is a huge issue. The microcirculation's been affected. So through the little tiny lenses, the mitochondria that make energy aren't working right because they're not getting oxygen and glucose. They had to switch to a different way of making energy, and that's called anaerobic energy. It makes a lot of free radicals, a lot of oxidative stress, and then a lot of inflammation. So there's downstream effects by not perfusing the tissues that forced it into this lens. So we're kind of looking at it backwards. We're saying, oh, that's a mitochondria problem. But the mitochondria are a problem because they're not getting blood flow.
Yes.
So what's with the perfusion? So that's one thing. And then the same thing with the immune system. The immune system is very messed up in these patients. Their antiviral immune system is not working very well. The immune system has sort of a life-saving trick that if you put your thumb hard on the on button and it doesn't release, the cells go into something called senescence. They essentially go to sleep. It protects them from dying because otherwise they apoptose and they die. They're gone. So if you look at the immune system in long COVID, ME/CFS, and in the other illness we study a lot, Gulf War illness, there's a senescence. The immune system's gone into hibernation to protect itself. Well, that is also potentially, partly, perfusion, because if the cells aren't being delivered to the tissues where the infection is, the infection persists and drives. Antigens are there, drive, on buttons pushed on hard, and the brakes are never put on, and so the immune system shuts itself down. And so again, the big picture is how much is perfusion the really biggest part of the whole issue? And if I tease the whole thing apart, I'd say the immune, that's a huge piece. And then making the immune system wake up and do its job, delivered to the tissues, that's another whole piece. So that's oversimplifying the whole illness, but it is probably two of the biggest issues. Now, in long COVID, it's shut down because the autonomic nervous system is out of balance. So normally you have a sympathetic and parasympathetic. You remember this from high school: fight or flight, rest, relax, restore. And it's in like a seesaw. If your sympathetic system, your fight or flight's up, then your parasympathetic shut off, which shuts things off. Your gut stops, peristalsis stops moving. It affects everything. It affects the way you sleep. You can't sleep through a sympathetic drive. There's many things wrong. So in these patients, they're in this kind of permanent sympathetic state where their parasympathetics are way down and their sympathetics are driven up. There's other illnesses that do this, like PTSD would be a great one, right? PTSD, very good example of that, where you get terrible sleep and long-term chronic health problems from being in this sympathetic drive. Well, during acute COVID, from 2020 to 2024, the number of people diagnosed with one of these sympathetic overdrive symptoms, an illness called POTS, postural orthostatic tachycardia syndrome, meaning every time you stand up, your heart rate way overshoots, right? The POTS diagnoses in this country went from 1 million people to 4 million people.
Unbelievable.
Is that amazing?
Incredible.
Crazy. 4 million people diagnosed with POTS. That's just one narrow window into long COVID, right? But those people are long COVID. So anyway, this dysautonomia, if you imagine your sympathetic system's in overdrive, what does it do? It vasoconstricts, right? And so your big arteries get tighter, but your little arteries go away. So there's this great group, two great groups, one at Harvard and one in the Netherlands. Dr. David Systrom did a study where he put people with long COVID and another group with ME/CFS. And we're not talking about a few people, we're talking about hundreds of people. Really good study. He puts them on a bike. He drops a line into their heart. He drops an arterial line, a venous line. He does an exercise stress test with all the metabolic cart where they're measuring carbon dioxide going in and out. Gets all these amazing measures. But one of the things that he showed was people with both of these illnesses fail to extract oxygen from their tissues, right? The oxygen coming back to the heart has the same amount of oxygen as what left the heart. Well, that wasn't supposed to happen, right? So that was a really important thing. Everyone's going, oh, that can't be good, but that can't be true. Well, this guy, Dr. Woest in Amsterdam, and his amazing team did it all over again. This time they did a muscle biopsy before and after the exercise. And what they showed was the microvasculature totally clamped down, right?
Yeah.
To the point that a red cell couldn't get through. And there were chronic changes. It wasn't just vasoconstriction. The membranes were thickened. There was amyloid in the membranes that was changing, that the microvascular couldn't let the blood through. There was ischemia, necrotic muscle tissue after a minor exercise challenge.
Wow.
Well, think about this. Someone walks into the doctor, I'm profoundly fatigued, I can barely move. The doctor says, you need to exercise more.
You're putting them into...
Oh, my goodness.
Yeah,
and so these patients will tell you, if you're listening, every time I do anything, it puts me into bed for 2 or 3 days.
Yeah.
Well, it does. They are not delivering oxygen to the tissues. So if you think about what you can do to help people, you got to do things that make their parasympathetic system come back, right?
Yes.
Now, there are things you can do that have nothing to do with drugs that do that.
Exactly.
In fact, some of the most effective PTSD treatments ever with transcendental meditation, right? I mean, putting people, but really aggressive, intense, real meditation where people go into these weekend workshops and really learn how to get it to the point where they're having physiologic changes because they get that relaxed, and then learning how through sort of a biofeedback loop to get themselves there quicker, and then do daily meditation. There's parasympathetic breathing techniques where you're just moving your diaphragm by huffing and puffing up and down your diaphragm, which is a vagal nerve, which is parasympathetic nerve, so you're driving it. There are parasympathetic drives that are vagal stimulators that people can buy to stick right behind their ear or on their neck. There's one right now, I've just been testing it out in the lab. It's called Pulsetto. It's not even very expensive. It just sits right on by your carotids.
The carotid, yeah.
And it does vagal stimulation. So there are different ways to try to, and it's not fast. It took years, at least months, but sometimes years, to get so out of balance that the superhighways in your brain that regulate this are sympathetic.
Exactly. Yes.
And trying to get a balance back and get that normal signaling pattern back that's more balanced, it takes months and months of real personal hard work. It's not just, here, have a medicine. I can fix that. It's like, you need to put in vagal nerve training. And these are all the things you need to do to try to do that.
Well, thank you for highlighting that. So this is like an autonomic rehab, really.
Essentially, yes. It's what the astronauts have to do when they come back from space. They are completely dysautonomic, and they're in sympathetic overdrive.
Exactly,
and they can't even stand up. You don't get to see them when they land, right? Do they show you where they are? Because they're on stretchers. They can't put their heads up.
So how can we then translate the information and the knowledge that we have there that we're helping astronauts with, and have these different programs for transcendental meditation, streamlining this for the greater population to use and utilize?
Yeah, there's many different ways to do it, and we in our group at Nova Southeastern, it's a part of the bigger program. They come in, and what is the first thing we do? Pacing. You can't believe how awful it is. Just the stories we hear of what people have been told about how lazy they are, and and you're like, oh my God, you don't have to beat up sick people. You actually need to help them.
Absolutely.
And and then some of this is white coat stuff. After Hurricane Andrew, we did a study after Hurricane Andrew for ME/CFS, where in Miami, where we were devastated, and Fort Lauderdale was spared. So we went in and found our ME/CFS patients and did a PTSD assessment. And I needed a control group, so I used Fort Lauderdale.
Yeah.
Wow, the PTSD rate in our ME/CFS group in Fort Lauderdale without a hurricane was incredibly high. And the instrument that we used to measure it made you write a paragraph about what your nightmare was. What was your recurrent PTSD experience? And it was doctors dismissing their illness in prerogative ways. And they all had stories. You need to go, you need to divorce your husband because clearly, these horrible stories. And it's a woman in medicine thing. It's like, these are women being told mostly by guys, buck up, get tough. It's got to be, seriously, I've had people say, it's your sex life, and you're like, I have a person with a chronic neuroinflammatory disorder that's so disabling they can't work, who was an amazingly productive and healthy person before this happened. And you judgy white coat person who swore first do no harm, you know.
Exactly. It's part of our Hippocratic
Did more
Oath.
harm than the friggin' disease, you know.
That is horrible.
I know, it's horrible. That white coats could put a PTSD label onto somebody by our behavior is criminal.
So the physicians and healthcare professionals listening to our podcast hear the words from Dr. Klimas, and let's really take it to heart to recognize that we have humanity first. We treat our patients with that human heart
first. The big thing is, if you don't know what it is, that's okay.
Exactly.
You just say, I don't know what it is. But if I don't know what it is, so it can't be real. That is a leap of egoism.
Yeah. Unacceptable.
Extraordinary.
Yeah.
Yeah.
Not okay in any sense. And you know, this is an important conversation. This is a community of people who've been dismissed and belittled and told that they're making things up. So thank you for shining a very important light on not only the disease state itself, but also ways that we can actually, you know, navigate it in a positive way, like you said, to rebalance that sympathetic and parasympathetic system and get out of dysautonomia as a major pillar to treating this. Are there other modalities that work complementarily to, you know, sort of the autonomic rehab?
Yeah. So, like I say, we work on perfusion. That matters, okay? But inflammation is a big piece of this, and neuroinflammation. So imagine this, that in your brain, there's a little, it's not huge, it's not like multiple sclerosis level of inflammation, but it's a lot.
Yeah.
Enough that the places in your brain that need to talk to each other are not quite hearing it. For the older people in this audience, do you remember CB radios? You had to get the gain just right, or there was just too much noise to get the signal through. I always imagine it just like that. When the inflammation's so high that the subtle little signals that keep us from minute to minute, second to second, regulating things, your heart rate regulates beat by beat. Every single beat is registered by your nervous system and adjusts the next beat. That's how fast the system works, right?
Yeah.
So if it's just a little bit noisy up there with inflammation, things don't work as it may be subtle, but the clinical impact is not so subtle. It's particularly true with hormones. So your hypothalamus and your pituitary gland are up there regulating your adrenal gland, your thyroid gland, all your gonadal hormones, all your estrogen, testosterone, all that. And it's your adrenal gland is reacting instantaneously to stress by making cortisol.
Yeah.
So a long time ago with the ME/CFS population, I was always having to sit next to 8 psychiatrists and then me in big public things where I was the voice of, quite frankly, reason, because they were saying, you know, psychiatric disorder versus biologic disorder. And I always liked the picture of the adrenal gland. If the adrenal gland hasn't been getting enough signal from the brain, it physically shrinks. It's smaller, right? So people with depression and other psychiatric disorders, their adrenal glands are bigger.
Yeah.
They're enlarged because they're making so much stress hormone all the time. Whereas because the brain's signaling is blunted in these illnesses and the hypothalamus and pituitary aren't reacting minute by minute to the stress signals, the adrenal gland's actually reducing its ability to make enough of everything. And now you could say, you remember those old pictures, your brain on drugs, you know, with the eggs frying or whatever? I always thought about that. And I would show a picture of the tiny little adrenal gland, the great big adrenal gland, and the nice little middle-sized, Goldilocks adrenal
Exactly,
glands.
the one that's just
and
right.
I'd say, and this is not normal.
Exactly.
This is so close to Addison's disease that it's almost there, right?
Yeah.
So and that was just the adrenal gland. It's also true of the thyroid. And we don't think of the thyroid as a day-to-day reactive thing, but it is. It's a very reactive, and there's more than just one little neuropeptide going on in your thyroid. And then all the gonadal hormones, which really matter, and the normal cycles. So as a physician, with the women, you can ask about their cycles and how they behave, and that gives you a sense in a kind of big way of whether or not there's normal signaling going on. But and there's not. But but all of that matters. So and that's as a result of neuroinflammation and perfusion. The two things together. And you could say, why is there inflammation in the brain? You could go back to oxidative stress. It matters. and but also viruses. So viruses reactivate in these illnesses. The immune system's broken enough. And you'll see it as a clinician. You can ask about shingles and things that are obvious, you know. But the less obvious ones, Epstein-Barr virus, CMV, HHV6, these are your old mononucleosis viruses or 3-day measles viruses from your childhood. And they're all in the same family. They're all latent. We all have them. We have them forever.
Yes.
But if your immune system surveillance falls down, they start creeping out. And normally we think of it as like an aging thing, and people in their 80s and 90s have a lot of viral reactivation because their immune system's memory, amazingly, didn't last 80 years, which is extraordinary when you think that it did last 80 years. I think that's kind of amazing. But in these younger people, you see because their cytotoxic T cells and their NK cells are not doing a very good job. These viruses start reactivating. And then it's a vicious cycle. The immune system's inflammatory. There's a lot of antigen out there to drive it. There's a lot more inflammation signal. And it's systemic and in the brain.
So that viral reactivation and the manifestations of other chronic illnesses that we're seeing a rise in, we're not really seeing too much of a dent, you know, looking at heart disease, diabetes, other what we call chronic
all
preventable.
That, you know?
Will it really be preventable then if we have this higher baseline of inflammation that's happening and constant insults to the immune, regulatory system, ramping things up?
Right. Well, it's a problem. Now, you're going to take the good side of this. We're learning so much now because of this, right? And so we've known for a long time that chronic inflammation matters a lot in cardiovascular disease.
Yes,
right?
very much so.
I think we can all
Absolutely.
say that. That's why diabetics have such terrible cardiovascular disease.
Yes.
But now with this type of new knowledge and starting to untangle what do we mean by inflammation? What's driving inflammation? Is there anything in there that's treatable or preventable?
Yes.
What is the role of vaccines going forward? And then I know we could talk about vaccines as people that overreact to vaccines, but there's also the majority of people who, in fact, don't overreact and get a very nice immune response to vaccines. What if we had an EBV vaccine? What would it mean to these people with these illnesses?
Exactly.
But what would it mean to an 85-year-old? To not have to deal with viral reactivation? What would all of aging be like if we didn't slowly smolder up our low-grade latent viruses and reactivate them? It's really an interesting question.
And it deserves more study. Let us see. We can solve a lot of world problems and a lot
You
of
want to know
disease states.
another place
Please,
that
go
you
for
don't
it.
ever learn anything about in medical school? The virome of the GI tract. You know, we think about E. coli and yeast and all the things that digest your food and pathogens in the gut. But there's a virome of the gut. And it's a player too. And it reactivates. So in this disease, if you do gut biopsies anywhere along the GI tract, doesn't matter, what do you see? EBV reactivation, CMV reactivation, HHV6. But secret viruses you never get to see in the periphery by drawing blood, Coxsackie virus, enteroviruses, entero, gut, viruses. And they're all latent viruses that hide out in the gut. And if they start reactivating, then your gut has a chronic viral exposure that the immune system has to respond to. There's no place in your body with more immune system than your gut. Every knuckle of my thumb is a lymph node all the way down your gut. And how many yards and yards and yards and yards and yards of gut are there? That's a tremendous amount of immune exposure because you need it because there's a lot of, stuff going by there.
Absolutely.
And if the mucosa of the gut breaks down, and it does, and normally there's multiple layers that prevent the things in your gut from being seen in the bloodstream. But if you lose the mucosal layer, if you lose some of the immune protections, IgA antibody, which is a really important part of your gut protection system, then things can sort of slip through and be seen by the immune system, which is there in huge numbers.
Absolutely.
So where is all this chronic immune activation going on? Mostly along the gut. All right? So then the provider needs to think, what can I do to make a healthier gut? And one is don't overuse antibiotics. Because we really mess up the microbiome.
Absolutely.
But the other is, pay attention to what is this thing that used to be just considered crazy but is now very real, in all of our minds, leaky gut.
Absolutely.
Leaky gut's a thing. And it means the immune system's seeing things it shouldn't be seeing because the normal barriers aren't there. And there's simple things to do about that. It's got to do with what you eat. Putting more fiber into your diet, having healthier things in your diet, less inflammatory foods in your diet. You
More
look that one up,
plant-based.
y'all.
Yeah.
Inflammatory foods, they're not good for you.
Exactly.
Basically, if you can get it in a drive-through window,
Yeah,
don't get
not
it.
okay. Right. Exactly. Avoid the drive-through. Absolutely. In the garden to table, farm to table.
Garden to table, yeah.
You know, those kinds of things. And so, the virome of the gut, that's a very, very important piece to highlight, right? And mentioning the immune system getting a sneak peek into some of these other pathogens that maybe it shouldn't, and it's revving it up further, et cetera. What have you seen science-wise with GLP-1 drugs and this virome and how that potentially can impact the clinical course?
So the GLP-1 drugs aren't themselves the problem. It's what people eat when they're on GLP-1s. Because remember, they have no appetite.
Right.
So now they have to think what every single bite brings to me. Because if it didn't bring you anything, that bite shouldn't have got into your mouth. Right? Because essentially you're eating a third as much as you did before.
Exactly.
So now you really, really need to think about fiber foods, green, rainbow diet. The rainbow diet, eat foods with many different colors because they all have different types of vitamins and nutrients they bring to you. And then protein. One of the things that happens with GLP-1s is you break down, if you don't have enough protein, is that you break down muscle and immunoglobulin for protein. Now your immune system is getting dinged because you're having to use your immunoglobulin as a source of protein, and it's not available to protect you against the stuff it's supposed to be doing.
Wow.
Yeah.
That's very important information.
So they say, what, a gram of protein for every kilo? Is that right?
Yeah.
Is that the math of it? If
Yes.
you're 70 kilos, you're supposed to eat 70 grams of protein a day?
At least, yeah. Exactly.
Right.
Wow. So that is an important piece, yet some more study needs to be done in that area and how it'll impact the disease state.
Yeah. So I think that's that. So when I was talking about immunoglobulin, you have that in your gut. So if you're digesting it for protein instead of using it for protection, then you're not going to you'll have more leaky gut.
You will have more leaky gut, and it's another insult to the immune system. So what happens you mentioned neuroinflammation earlier. Are we seeing dementia, for example, happen in younger age groups now?
So what happened during acute COVID, we found out very quickly, is the people that were on the slow path to neurodegeneration jumped on the fast train, right?
Yeah.
So you had people with Parkinson's that didn't need any drugs, and all of a sudden they needed all the drugs. You know, what went on there? People with mild cognitive impairment that now had full-fledged Alzheimer's. So that has been definitely true. That neuroinflammation is not good for your brain. And that's still going on. I don't think we're counting the numbers as much as we did because during acute COVID we were watching so closely for everything. And I haven't seen any recent, post-pandemic, but still COVID's still there. I mean, let's all be clear. We're all getting COVID infections all the time still, but we're not having as many hospitalizations and not as many serious life-threatening COVID infections thanks to herd immunity.
Right.
But we're all still getting this COVID. Another thing about COVID that we're doing, and it brings up this great question, and it's kind of a microbiome question too, which is one of the reasons why your immune system stays activated is that antigens in the system, right? Yes. So there is some data, not in everyone with long COVID, but in at least 25% and probably quite a bit more, that they still have spike protein long after their COVID infection. So that is a bad thing to have because spike protein is the thing that bound the virus to the wall of your blood vessel, the ACE receptor. The ACE receptor regulates autonomic function.
Very much so.
So it's like a very targeted thing. And it's a real puzzle. Why would an infection... There are different types of viruses in the world, and they're the viruses that stay latent. Those are the herpes family viruses like EBV and CMV and HHV6. And the shingles virus, chickenpox virus, and then the enteroviruses, they all stay latent. Retroviruses are latent. But cold viruses, common cold viruses, they're hit and run, right?
Right.
You got them, they're gone.
It shouldn't stay.
And
Right.
COVID is a coronavirus, which is one of the cold viruses.
Right.
It comes from the family. Causes about a third of the viruses that cause colds are coronaviruses.
Yeah.
So we don't think of those as viruses like diddle around later. You know,
Right.
you got them, you get over them, you move on. So here we are with a virus that's a coronavirus. It's not supposed to be latent. It's not supposed to be persistent. But we have people who are a year and longer after post-COVID that still have spike protein. So the question is, did the spike protein get made during your acute infection, deposit so much of it that it's just going to be there for months and years, you know? Or is it that the virus persisted, which there is a tiny little bit of evidence from a couple groups that might be true. And or is it that the message for spike protein got transferred to another cell, like your microbiome in your gut, and now it's just because that does happen, that the microbiome can shift, message around, and
Absolutely.
you can put in a penicillin-resistant, strep or staph bug in your gut, and now the E. coli in your gut are penicillin and strep resistant because they transferred the drug resistance by transferring the message.
Yes.
So that can happen. So there's all these different kinds of hypotheses. But it led to us doing a study that's underway right now at our site using a monoclonal antibody for spike protein to treat long COVID. And we're in our final 2 months of recruiting that study, I hope. I hope we finish our recruitment on time. And so we'll know in about 4 or 5 months if we're on the right path. Yay for us.
Yeah.
But we're trying to mop the spike protein out of the system with a monoclonal antibody that is lasts for up to 6 months. So we'll see if we're on the right path. But that's kind of a moonshot study, but it's
very much
exciting.
is. I'm very excited about that study, actually. It's incredible to see this in progress. And you have some modeling data and so forth that you always use.
Some great
to
translational science work. We were so lucky at the Institute for Neuroimmune Medicine at NOVA because we are a group of basic scientists, amazing laboratory scientists, genomics, Dr. Nathanson's group, the laboratory immunology with Dr. Enley and just an amazing group of scientists, and then Theo Harris, Theo Herrerides, who's a mast cell expert and neurodegenerative, Kemparaj Dharasamy, who's a neurodegenerative disease in the brain neuroinflammation expert. These guys are all in the laboratory working on in vitro models, laboratory cell culture type models of testing different types of interventions. They're partnered with our computational science group that uses AI and other technologies to model the complexity of the illness and predict what the interventions might be.
Incredible.
Yeah, it's very exciting work. It's like, it's
moonshot to the 10th power.
Totally cool. But what's neat about it, and what I love about it, and why I thought this was so important, in academic medicine where we sit, these scientists usually do their own thing, and the clinicians do their own thing. And the space between translating all that knowledge that these amazing, smart people in the laboratory and in the computational sciences do never gets to patient care because they never partnered with a clinician partner that could move it forward. So we created an institute that's a translational science institute with a huge team under Dr. Aman Chima's group to translate the work that we're doing into clinical trials and actually move it to the point where we're able to move it into care. And the same thing with our laboratory. The laboratory, which is a research laboratory, has a reference CLIA laboratory component. So we can discover a new biomarker and move it right into the clinic. We can start using it because we can validate that marker and move it into care.
That's incredible.
It's really exciting, yeah.
And you designed this system, essentially.
I'm
Incredible.
like the team builder.
Yes, you are.
Mine is the team builder. And then they put me in this terrible job, which is the director, which means I'm supposed to be an administrator. And I'm terrible at it. I just admit I'm a dreamer, I'm a schemer, but I am
big picture
so bad at HR.
Oh, gosh. But thank God for you, honestly, and your creative energy and the intellect from pulling knowledge from all these different places to create this expedited track, to translate this knowledge to real world.
You know where the passion comes from. We sit with our patients and they're
love
sick.
It. Absolutely.
You know, that is the difference.
That's it.
When we first did the Institute, they didn't have that pretty building we're in right now. So
Beautiful
we were all
building.
squished together in this little space, and the patients were, waiting room was our door entry room.
Wow. Yeah.
So all those basic scientists had to walk through a waiting room of patients. It's total HIPAA violation. Sorry about that. But it was a long time ago, so don't get me.
They've evolved.
Potentially before the HIPAA rules came.
Yes.
But anyway, the patients would reach out to these folks that had never seen a patient and say, thank you for the work you do. Now, for me, they thank me all the time, and they thank me for the whole team.
Yeah.
But it's so beautiful when the people doing the work see the impact of their work in a real life. Yeah?
That is absolutely
so
beautiful.
special.
I love that. So thank you to you and your amazing team. You each hold such a different role, as you said, and it all comes together synergistically for the benefit of humanity.
Yeah.
So thank you for that. This is real medicine with heart. Well, Dr. Klimas, do you have any other words of wisdom you want to share? Any other patient stories, perhaps, that you want to highlight to show the impact of pulling all of this together? And even think of any other preventive strategies that you maybe want to shine a light on.
First, I want to thank some of our patients. We've been lucky that we're at Nova, and that, I won't go down the story how we landed here, but there was a good reason.
Yes.
Because here we can do what we dream to do.
Yes.
And one of them is take care of everybody, and we have some extraordinarily generous patients some who can afford it, some who can barely afford it, who donate to help support the work that we do. And right now there's a big matching campaign because we have a donor that's donating $500,000.
Incredible.
And we're going to try to match that with another $500,000 worth of, $5, $10, $15 donations, but try to grow it. Because when we do that kind of work, when you write a grant, if you have a genius idea, you write a grant, right? Well, that takes a few months. You submit it. It takes about 9 months for the review process. You never get it the first time or once in a blue moon.
Exactly.
Then they give you, some criticism, and you go back and you fix it. You do it all over again. Another 9 months goes by. So now it's about almost 2 years from the time you had the idea before you get to implement anything on that idea. That's the normal thing, right? So when you're working from a donation, you have an idea and you act. Right?
Yeah.
And you can develop at least the pilot data that makes a stronger application when you're going for federal money or some other money. So we live on donation because we're in a hurry to try to get people better. And if we didn't have that donation pot, we wouldn't be able to do what we do. But the donation pot also supports the patients who can't afford to come.
Absolutely.
So we have this Grateful Patient Fund, and we have a pot of money, and whether you're rich, poor, in between, we try to take care of as many people as we possibly can. And the podcast series that we do is also for that.
Absolutely.
And that's been a very successful podcast series. So
fantastic.
And it gives it's meant to give patients the little pearls. You should walk away from one of our podcasts with something new that you might be able to try.
Absolutely.
Yeah.
Well, everyone, please go on our website for the Institute for Neuroimmune Medicine. We find the campaign information there. If anyone wants to support or share it with others, absolutely. This work is so important and will impact our world, in great ways. So we appreciate that. Anything else? Any other final words of wisdom?
Hope.
Yes.
Just hope. I just really want to. One of the biggest tragedies is when someone gives up. And in my world, in this chronic, horrible disease that causes so much suffering, people lose their lives to suicide. And I consider it such a tragedy because we really are making big progress. And CFS, we were so underfunded for decades, and I could go on about that, and we still are underfunded. But the long COVID group, when that came along, Congress recognized the problem early.
Yes.
They didn't wait for it to become, they put more than $1 billion into a research fund that initiated a really serious international effort to find answers. Now, a lot of countries have come along. Germany's put a huge amount of money into this. Austria, I was just at an international conference. I was just so impressed with the progress in other countries. And anything we learn from that work is going to affect the ME/CFS group, which I'm grateful for. It's going to affect everybody, because learning about what does it mean to have inflammation, what does it mean to have a viral infection, what does it mean to have a permanent inflammatory signature after what should we do about that? Who else needs care? Even the ones who maybe don't have this big boxed illness and are clearly fit in this box. There's another group of people who are smoldering. All right, we have a long COVID study by the CDC funded. It's called COVID Up. And we have a recovered group and an unrecovered group. And in the recovered group, almost half of them aren't recovered. They perceive themselves as recovered. Mm-hmm. But when we go digging in deeper, even on just symptoms, they're not recovered. They just bolt on through with their lives and don't associate that the drop in their health that happened after COVID had anything to do with the virus.
Wow.
It's really something.
Yeah.
So, I think we're going to learn a lot. There's a lot of money in this, and it's going to matter to the people with long COVID, but it's going to matter to all of us. I think that we're all going to hopefully have a bigger toolbox to play with. Meanwhile, breathe, work on your parasympathetics, pace, don't not exercise, but don't push it to the point that you're relapsing. And I always say do it in little bits multiple times during the day, like 2 or 3 minutes, and then take a big break, and then 2 or 3 minutes, and work yourself up to 15 or 20 minutes a day that way. It's much safer than trying to go to 20 minutes. But so there are things you can do to keep yourself from making yourself sicker. And watch your human nature. When you have a good day, don't ruin it by trying to do everything on the list that you've been working on for a while to say, when I have a good day, I'm going to go, Christmas shopping. Don't do it.
That's right. Honor your body and honor how you're feeling in that
easy.
moment.
Go slow.
I love that. Well, Dr. Klimas, thank you so much for being here.
It's
you
a
really
pleasure.
are incredible, the work that you're doing as a team. We're excited to see what else is coming forward.
I'm happier with working with the people I get to work with, and being here at Nova Southeastern and being supported by a university that really gets it and has the mission of trying to make the world a better place. So
beautiful.
that feels good, particularly right now where the
we
world
need it.
feels a little bit not so good.
Together we'll help and heal. I'll just say it again.
Yes,
we need that
exactly.
for all of us. Well, thank you again.
Thanks.
And to our viewers, thank you for joining us on this episode of the Health and Happiness Podcast. I am Dr. Farzanna Haffizulla. Please join us again soon. If you're viewing this QR code on your phone, an easy way to access the link is to take a screenshot of it and then long press the QR code from the screenshot picture. Your phone should recognize it and take you straight to the video.